Today, our talk is titled Prophylaxis and Glomerular Disease. We're very excited to have our speaker, Dr. Corey Cavanaugh.
So thank you for having me. Thank you for the invitation. I've given this talk or a version of this talk a little while back. So it's going to be sort of a continuation of that with some updates. But the topic is prophylaxis in glomerular disease, which is a pretty broad topic. But as I've learned over the few years in having dedicated glomerular disease clinics, it is very important to get detail oriented and not miss these things that can sometimes see out of focus when you're talking about choices on immunosuppression. But I can, as we'll go through, hopefully I'll clarify the importance of crossing all of your T's and dotting your I's when it comes to protecting the patient from complications of glomerular disease. Like I said, we'll just discuss the pathogenesis of thrombosis with some updates in nephrotic syndrome, the treatment options, and then moving on to antibiotic choices and prophylaxis in glomerular disease, and then just discussing the risk of infection and the drivers in glomerular disease. So kind of a broad topic, a lot to discuss, but hopefully engaging. Okay, so let's just start with the conventional wisdom of nephrotic syndrome, sort of how we were taught probably fellowship, medical school, that sort of thing. So the anatomy of a thromboembolism in nephrotic syndrome, we tend to think of the more common presentations, which would be renal vein thrombosis, DVTs, and PEs. There's a really wide range of incidence depending on what you read, and the reports of these findings can be anywhere from 3 to 36%, depending on the cohort being studied. So it's very hard to nail down how common it is. Luckily, arterial thromboembolism is much more rare, but there are uncommon to rare presentations of clots with sort of devastating, I'd say, consequences. So things like cerebral artery or venous sinus thromboses. Rarely you'll see a Budd-Chiari presentation, portal vein thrombosis. Once have seen a coronary artery embolism. So it can be all over the map and sort of keep us white-knuckled through it all. So things to be aware of. The pathogenesis, this is sort of what we've been taught, I think, since the beginning, which is this balance of production of procoagulant proteins, factor V, factor VIII, fibrinogen, things like von Willebrand factor, high cholesterol. There's a role for platelet activity and aggregation being increased in nephrotic syndrome as well. While simultaneously in nephrotic syndrome, of course, we're losing anticoagulant proteins. Probably most talked about or discussed would be the antithrombin 3, but also we're losing things like plasminogen, protein S, and plasma. So putting that together, it's a production of a procoagulant and loss of fibrinolytic and anticoagulant proteins that seem to make this drive this pathogenesis of clot and nephrotic syndrome. So let's just look at a big sort of observational registry study out of Toronto, and this is now over 10 years ago from Sean Barber in Toronto. But the overall cohort of around 1,300 patients, nearly 400 of which had membranous nephropathy highlighted there, had an incidence of around 8% VTE in the group, comparing it to IgA, which could sort of be your normal comparator. FSGS coming in around 3% over in the middle column there. So I think this is kind of how I operate in terms of thinking about the relative rate or incidence when it comes to VTE and nephrotic syndrome, and membranous, of course, being the one of most interest and most thought about, I guess you could say. So the disease-specific risk factors for VTE in this multivariate analysis of that data, the authors and investigators concluded that membranous does have a greater risk of VTE compared to FSGS or IgA, as previously had shown you, even after the adjustment and degree of proteinuria, hypoalbuminemia, and malignancy. So there's something about membranous that makes it more thrombogenic. And let's explore that a little bit. The timing is one thing to consider. So in terms of when the clot appears or when it's discovered, vast majority, around 75%, occur within the first 2 years of diagnosis. And this is coming from the GDCN group cohort and Toronto, so almost 1,000 patients. The median time is around 4 months, but there's definitely a portion in which it's discovered before the biopsy or even at the time of presentation. That's how the membranous or nephrotic syndrome is discovered. So at very least, these patients should be anticoagulated in that first year, perhaps beyond, depending on how things are looking.